Okay, so good morning, everybody. And today we have Neil R. Miller, an international icon at Johns Hopkins for the last 45 years as the Frank Walsh Professor of Neuro-Ophthalmology at the Wilmer Eye Institute. He's published over 570 articles, 93 book chapters, and 13 books, including the landmark 5-volume Walsh and Hoyt's Clinical Neuro-Ophthalmology, which weighs 32 pounds. He's delivered more than 59 named and keynote lectures at forums including the American Academy of Ophthalmology, Oxford Ophthalmological Congress, the European Neuro-Ophthalmology Society, and forums in Singapore and in Canada, the Sally Letson. He's been president of both the North American and International Neuro-Ophthalmology Societies. Neil's a friendly neuro-ophthalmology giant who, like Walsh and Hoyt, has hoisted numerous trainees on his shoulders so that they could see further. The 77 fellows that Neil's trained are who's who in neuro-ophthalmology and include department leaders in many of the world's most distinguished institutions. On a personal note, Neil's accomplishments are all the more inspiring because he generously bestows his time, knowledge, and academic opportunities to others, but insists on receiving nothing in return. So in summary, Dr. Miller is the neuro-ophthalmologist, and a role model for collaboration and mentorship. We're indeed privileged to have this master clinician discuss his high-yield updates in neuro-ophthalmology with us this morning. So I'll share this, put the screen share back to you, Dr. Miller.
Well, thank you, Edsel. It's a real pleasure to be with you today. And let me just share. Are we all set? Can you see my slides?
Yep, looks perfect.
It's a pleasure to be with you. I wish I could be there in person. But I think this will be, I hope, fun for everybody. I'm going to start with a case. All of the subjects I discussed today will be started with cases. And the first is a 23-year-old woman with no past medical or neurological history who presents with a 3-day history of painless decreased vision in her left eye. Her vision and color vision are decreased. She has reduced sensitivity in her fields of the left eye. There is a left relative afferent pupillary defect, and the left disc is swollen. And here you can see the right disc looks perfectly normal, but the left disc is swollen. There may be a little bit of a hemorrhage here over at around 9 o'clock. And this, of course, is acute optic neuritis, not surprising to anybody. Decreased central vision that can be anywhere from 20/20. Just because somebody has 20/20 vision doesn't mean that they have normal vision. And some people struggle with the 20/20 line where others can easily read 20/15 or better. There's always decreased color vision. Any type of field defect may be present, arcuate, altitudinal, even hemionopic. But a central field is generally affected. Of course, there should be a relative afferent pupillary defect unless something happened previously to the retina, the optic nerve in the other eye. And of course, we recognize two forms of optic neuritis, the retrobulbar form, which occurs in about 2/3 of patients with idiopathic optic neuritis, or the swollen nerve, in which case we call it anterior optic neuritis or papillitis. If we think about the etiologies of acute optic neuritis, the vast majority are still idiopathic or MS related. However, there are those caused by a systemic infection or inflammatory disease, sarcoid syphilis, Lyme, TB. We're all familiar with those. And of course, unfortunately, COVID has produced a large number of cases of optic neuritis. There are also drug-related, which are probably primarily an inflammatory reaction to TNF-alpha inhibitors, PD-L1 inhibitors, checkpoint inhibitors, etc. So in the absence of evidence of a systemic infectious etiology or history of some sort of causative medication, the usual assumption in a patient with acute optic neuritis, such as the patient that I just described, is usually that it's idiopathic or it's a presenting sign of MS. However, whereas the acute Idiopathic MS presenting optic neuritis usually has pain, especially on movement of the eye, usually associated with normal optic disc. This patient did not. No pain and disc swelling. And therefore, you have to think of something else. And when we look at this list, we have to add the association with both anti-aquaporin 4 antibodies, so-called NMO spectrum disease, and an association with anti-MOG antibodies, MOGAD. And if you look at these two entities, it's really important to recognize how they differ and how they're the same as, differ from or the same as the acute idiopathic optic neuritis or MS-related optic neuritis that we all thought was the be-all and end-all. So for NMO spectrum disease, it's often, as in this patient, anterior and may not be painful. It often has extensive optic nerve enhancement on MR, and I'll show you that in a moment. And this condition requires treatment different from that of MS. MS drugs, interferon, Copaxone, etc. If you give those drugs to a patient, assuming that that patient's optic neuritis is idiopathic, you may very well make the patient worse. The patient requires steroids, yes, but something different. Various immunosuppressive agents, the monoclonal antibodies, eculizumab, satralizumab, tocilizumab, or Plex or IVIG or something of that nature. Unfortunately, recurrences are very common in NMO spectrum disease related optic neuritis, and the prognosis is poor unless you really hop on this very early. And there's a very nice paper from the UK last year reviewing this. How about anti-MOG antibody-related disease? It's also usually anterior, sometimes associated with peripapillary hemorrhages. It's often painful, but it's also often bilateral, which separates it from the typical idiopathic or MS-related optic neuritis. And it appears to be the most common cause of optic neuritis in children. Recurrences are very common, especially in Caucasians. But what's fascinating is that unlike standard optic neuritis, which often doesn't show anything with respect to the optic nerves on MR, and unlike NMO spectrum disease, which generally will show, in a case of optic neuritis, enhancement of the nerve itself, anti-MOG antibody-related optic neuritis shows perineural enhancement. That is, it's an optic perineuritis or a perioptic neuritis, some people call it. Again, like NMO spectrum disease, it requires steroids, but also if the patient is not getting better, it's best to Plex those patients. And unlike NMO spectrum disease, it has a pretty good visual prognosis. Here you can see the difference in MR imaging in aquaporin 4 antibody-related optic neuritis versus anti-MOG antibody-related anterior optic neuritis. And on your left, you see this diffuse involvement of the optic nerve. And on the right, you see the perineural involvement. Hopefully you can see there's actually some disc elevation on both sides, but it's the perineural involvement. And you can see this. We just saw a case yesterday of this. Notice, by the way, for those aficionados, notice that the enhancement of the optic nerve sheath is not absolutely pure. There are little tiny extensions into the perineural fat. And this is typical of the perineural positivity of anti-MOG related optic neuritis. And the differential is with an optic nerve sheath meningioma or sarcoid. They all three show things that are somewhat similar. So what's your change in practice? Consider the possibility of NMO or MOG in all patients with acute optic neuritis, but particularly if it's painless, if there's a swollen disc, if it's bilateral simultaneous. I believe that it's appropriate, and I don't know what Edsel and his colleagues do, I believe it appropriate to obtain anti-aquaporin 4 and anti-MOG antibody assays, cell-based assays, in all patients with acute optic neuritis. The problem is we don't know when that patient comes in, especially to the general ophthalmic practitioner, we don't know if that is going to be really horrible and is related to NMO or MOG, or if it's just your standard optic neuritis. So I feel that it's safest to change your practice, if you're not doing so, to obtain anti-aquaporin 4 and anti-MOG antibodies. And this is the biggest change that's occurred in my practice. I used to say to patients, well, we know that in idiopathic optic neuritis, treatment with high dose and then low dose steroids over a couple of weeks will speed recovery. It won't change the ultimate outcome, but it will speed recovery by maybe 40 days or so. And you'll get to where you would have gone anyway, but it's faster. Here, the treatment with aquaporin 4 or MOG-related antibody optic neuritis will make a difference in the visual prognosis. And I don't know when that patient sees me 24, 48, 72 hours after developing visual loss, if that patient might have one of those disorders that is dependent on early treatment with systemic steroids. So I now, instead of discussing, well, you could have steroids, and if you have steroids, it'll speed your recovery, instead of saying that and saying, well, if you don't want steroids, no big deal, I begin all patients with acute optic neuritis on high-dose systemic steroids, unless there's a history of sexually transmitted disease or Lyme disease or something that makes me feel it's something different. I also am prepared to institute plasma exchange if there's no improvement within 5 to 10 days, even if we don't have the antibodies back, because of the difference in visual prognosis. All right, let's go on.
There's just a question for you there.
Sure.
Dr. Wu is asking for the high dose steroids, IV or PO?
It doesn't matter. That's a great question. So often people talk about you give IV first and then you give PO. It has nothing to do with the route of administration. It has to do with the level of the dosage. And it was shown years ago by Jetta Fredriksson in Scandinavia that if you gave a gram of prednisone, she had 500 milligram pills made. If you give a gram of prednisone a day for 3 days and then 2 weeks of lower dose, you get the same result as we did in the optic neuritis treatment trial and the Japanese treatment trial, where we gave IV. So it's just easier to do it, at least I found it's easier to do the high dose with IV steroids. However, you can mix it into a smoothie and give the patient a gram of steroids with orally, and it'll be just fine.
Dr. Miller, before you move on,
yeah.
these entities that we've heard about in the last number of years, do you think perhaps more subtypes and more antibodies may be discovered, and maybe many of these idiopathic types will turn out to be a number of entities?
For sure. There's no question we saw a patient recently who had all the features of anti-MOG related optic neuritis, but who had negative MOG serology on 2 occasions. And, those are the ones where you tell the residents and the fellows, this should have been MOG related, but there's going to be other entities that we haven't described. In fact, one of them I will talk about actually in just a few minutes. Okay, well, let's talk about a 37-year-old woman with no past medical history, presents with acute loss of vision in the right eye associated with pain on eye movement. And again, She's diagnosed with having anterior optic neuritis. And as I mentioned earlier, she's treated with systemic steroids and has marked visual improvement within a few days. She called me back 2 days after I saw her and said, "This is marvelous. I don't know what that drug really does, but I'm almost back to normal." So we start her on a taper, but as we taper her, her vision worsens. So we put her back on steroids, and again, her vision improves. But whenever over about a month, whenever steroids are tapered, the vision worsens. And this is chronic relapsing inflammatory optic neuropathy, abbreviated to CRION. It was first described by Des Kidd in the UK in 2003. It is typically anterior, and the key is it's both steroid responsive and steroid dependent. Back in 2003, Dr. Kidd and Gordon Plant and Liz Graham all did their best, and this gets to what John was talking about. They did their best to find some underlying cause and were unable to do so. And I remember going to a meeting and asking Liz Graham in 2013. So 10 years later, they had gone back to look at their cases, and they still had no idea. Nobody had developed any sort of special disorder. However, we now know that CRION, the most common cause of CRION, is MOG-related, MOG antibody-related optic neuritis. Study just 4 years ago, 12 patients with CRION assessed for MOG antibodies, 11 were positive, 1 was borderline. That's pretty impressive, maybe not as Liu's paper a year later. 33 patients with 38 eyes that had CRION, 2/3 were MOG antibody positive. These were somewhat younger than the seronegative CRION patients, and they tended to have more ultimate bilateral involvement. But I think that then the change in practice is that if you have a patient who, and you haven't tested for MOG antibodies, if you have a patient with a chronic, recurrent, steroid-sensitive, steroid-dependent optic neuritis, check those patients for MOG antibodies, and that's going to be a different treatment protocol from standard acute optic neuritis. So just as Dr. Lloyd said, we are constantly finding new antibodies, new substances that are related to the development of optic neuritis. Well, let's switch gears a little bit. And I see there are a couple of questions. Let me just.
So yeah, there's a question here for you, Dr. Miller, about the sensitivity of these antibodies in detecting NMO or MOG or MOG acute optic neuritis.
Right. The sensitivity of MOG is about 99%. There are very, very few false negatives, especially if you use cell-based assays. As far as NMO, that's a little bit less. It's about 95% now, according to John Chen and the group at Mayo Clinic. So they're very high. They're not zero. And one of the interesting things, and it's a bit of a digression, is that we now know that certain types of inflammatory conditions and infectious conditions can actually stimulate MOG antibodies. So we had a patient who had, to cut a long story short, optic neuritis that was found to be associated with Rocky Mountain spotted fever. And it was clear, it seemed clear-cut. He had been tested for MOG and NMO antibodies and was negative, and then we found that he had the Rocky Mountain spotted fever. He had a minimal rash that had gone away when we saw him. In any event, he did well with steroids and doxycycline, and then tended to have more steroid-sensitive visual loss. And we retested him, and now his MOG antibodies were positive. So was that a false negative at the beginning, or did the rickettsial infection stimulate the production of MOG antibodies? I don't know, but I think it's an interesting issue. Okay. So now we have a 32-year-old obese woman complaining of 2 weeks of headache associated with brief, lasting only seconds, episodes of bilateral visual blurring. Her acuity and color vision are normal. The fields show just enlarged blind spots. She has no relative afferent pupillary defect, eye movements, slit lamp tensions, all normal. But she has this bilateral optic disc swelling. An MRI shows no structural lesions with normal sized ventricles, but an MRV shows transverse sinus stenosis on the right side. She undergoes a lumbar puncture with an opening pressure of 55, but normal CSF contents. This, of course, I tend to call it primary pseudotumor cerebri as opposed to idiopathic intracranial hypertension. I like the primary part because then you can separate it from secondary pseudotumor cerebri syndrome, in which you have, say, carcinomatous or lymphomatous meningitis or aseptic meningitis, etc. And there are all sorts of management alternatives. You don't have to do anything if there's no headache and the papilledema is really mild. You can give analgesics, again, if there's mild headache, but the papilledema is mild as well. But the mainstays are weight loss, acetazolamide, and various procedures that I'll talk about. Weight loss is the only consistently effective treatment. It was shown back 50 years ago with the Duke Rice diet that people with pseudotumor who lost weight resolved their papilledema, resolved their headache, etc. And in the late 90s, both Lenny Johnson and Mark Coopersmith showed that a fairly low, or it would seem a low percentage, although getting somebody to lose 10% of their weight when they're 400 pounds is not an easy thing to do, but it does, they showed, eliminate the condition or at least speed the resolution of papilledema. If you look at the literature, at least until very recently, most have recommended a formal program combining exercise and diet. And we've certainly, that has been our standard at Hopkins for ages. However, an idiopathic intracranial hypertension weight trial was a 5-year trial, just was published late last year. Clinical trial enrolled 64 with pseudotumor IIH, body mass index of 35 or higher in the UK, and they looked at the change in intracranial pressure as well as lumbar puncture, opening pressure, visual acuity, contrast sensitivity, etc., quality of life at 1 and 2 years. What they found was that bariatric surgery is better than a weight loss program, and that the effects continue for at least 2 years. And this is significant, not just because of what they say, but I can tell you that several years ago, we were at a meeting in which it was suggested that when I mentioned that we had a lot of trouble getting our patients to lose weight, we were told by this group, the Birmingham, England group, that they had no problems at all, that their patients easily went into weight loss programs and had great results. And to have that group now discuss the fact that the bariatric surgery is better is really significant. In addition, just within the last month, the group has published the paper indicating that the greater the weight loss, the greater the reduction in intracranial pressure, and that in their hands, you need a 24% weight loss to be associated with disease remission. And of course, this is unlikely that anybody's going to achieve 24% without bariatric surgery, let alone 7 to 10%. They also found that gastric bypass is better than either a band or a sleeve. So maybe endoscopic surgery is not as good. You do have to worry about things, especially Wernicke encephalopathy. And we do know that these patients will gain some degree of weight back, no matter what procedure is done. So the fact that these people have gone 2 years and are doing well, and in fact continuing to lose weight at 2 years, doesn't necessarily mean that they'll keep that. Having said that, your change in practice tomorrow should be to consider a referral for bariatric surgery instead of attempting to place the patient in a weight loss program. And we had a discussion in our group at our division meeting yesterday discussing the fact that up front, and I think this is really the key issue if you're not excited about referring for bariatric surgery, at least discuss the option of bariatric surgery when you first see the patient and are talking about how you're going to deal with the patient's headache and papilledema. So I think building a discussion of bariatric surgery, not to mention the fact that if you, assuming you have someone or a team that does bariatric surgery, letting them know that they may be seeing more patients of yours. Another issue deals with acetazolamide, and I'm sure everybody knows this one, but I still run into people who don't. We know that it reduces intracranial pressure better than weight loss alone. And we know that you have to begin with at least 1 gram a day. It's amazing to me, with all due respect to my colleagues in neurology, how often they put a patient on 250 a day or 500 a day. I think you really have to start with 1 gram a day and divided doses. And just for those who remember that acetazolamide is a sulfa-containing agent, it is not the same as the antibiotic sulfa drugs. So you can use it in patients who say, oh, but I'm allergic to sulfa. But now what we know is that the maximum tolerated dose of Diamox is higher than we thought. My old friend Ron Bird from WashU in St. Louis and later in New York used to say that you could increase the dose, but he didn't have any real evidence other than his own experience. But the IIHTT that was performed a few years ago showed that in those patients who were treated with Diamox, the maximum tolerated dose was 4 grams per day. And it only took about 3 months to get up to the maximum tolerated dose, and with no significant adverse effects. So it has a safety profile that's acceptable. And so your change in practice is, if you have a patient with pseudotumor who's not improving on 1 gram or even 2 grams a day of Diamox, you can increase the dose slowly until either you reach the maximum tolerated of 4, presumably, or things get better. I think, again, very much like the issue of discussion of bariatric surgery when you first meet the patient, I think it's important, if you're going to put a patient on Diamox, to make sure you tell the patient about all those symptoms that patients get: tingling of their fingers and toes, carbonated beverages have a metallic taste, insomnia, mood swings. If you let them know early on that these are common side effects, most patients whom you place on Diamox will tolerate it. Let me see. Okay. All right, case number 4. This is a 23-year-old woman with a 4-week history of headaches. Now she's experienced, again, brief seconds of blurred vision in the eyes. She's now having difficulty seeing to the sides. Her acuity is not bad, but her color vision is down in the right eye, and she does have a right relative afferent defect. Eye movement, slit lamp tension's normal. But here you see this sort of chronic papilledema, and now she's got a constricted field in one eye and a nasal step in the other. Again, this is pseudotumor, which we confirm with a normal MRI, severe left lateral transverse sinus stenosis, and an elevated opening pressure, again with normal protein and glucose content, no cells. This is somebody who you don't have time to play games with acetazolamide. You may, in fact, need to place an urgent lumbar drain as a temporizing measure. And this is somebody who may require some type of procedure to lower intracranial pressure. The commonly used surgical options are VP or VA shunts, LP shunts, optic nerve sheath fenestration, but I want to talk a little bit about venous sinus stenting. If you look at this paper from 2015, this is a meta-analysis of stenting versus fenestration versus shunting. Note the significant improvement in vision, and granted, fewer cases at that time, significant improvement in vision, in headache, and in papilledema with stenting as opposed to shunting. Subsequently, other countries have put in their 2 cents worth. The German experience, again, dramatic improvement, 88% improvement or resolution of papilledema, 84% of improvement or resolution of headache in a large series. Mark Dinkin and the group in New York at Cornell had a smaller series, but improvement in headache, tinnitus, transient visual obscurations, mean deviation, and 83% had at least one Fresén grade improvement in papilledema. And there were no severe adverse effects. So there is this huge advantage in venous sinus stenting that you see here. Rapid resolution. We know from work done by our neurosurgical colleagues in 2 different locations that if you measure intracranial pressure, it decreases immediately after venous sinus stenting. There's rapid resolution of symptoms and signs. It's actually more cost effective than shunting because you don't have the potential for infections and revisions. So your change in practice tomorrow is to refer patients with pseudotumor who require more than medical intervention and who have, and most of them do have, evidence of venous sinus stenosis for venous sinus stenting. My final case is an 8-year-old healthy girl presenting with decreased vision in both eyes, identified at her local school. Vision is reduced, color vision's reduced, her fields are grossly intact. She really couldn't cooperate for automated perimetry. She had a left relative afferent defect. Eye movements and tensions were normal, but both optic discs were pale. And you see on MRI this huge mass, intrinsic and extrinsic, involving the optic chiasm and both optic nerves. This is, of course, an optic pathway glioma. Many of these are stable, but some progress. You can't surgically attack them because obviously they're within, or a large part of them is within the optic nerves and chiasm. Radiation has been used in non-specific chemotherapy, vincristine, vinblastine, actinomycin D, etoposide, and the combination of TPCV. All have been used. But we can learn a lot from molecular genetics. This is just a mishmash of the pathways for tumor production with the RAS-RAF pathway for growth differentiation, the PI3K-mTOR pathway for protein synthesis and cell growth, and the AKT pathway for cell survival and proliferation and metabolism. And you can attack these areas specifically with specific drugs. And the reason you can do that is that we now know that there is a gene called the BRAF gene that produces a protein, part of that first pathway I showed you. Increased BRAF in astrocytes causes this activation of these pathways, leading to the development of astrocytomas, pilocytic astrocytomas, which is what an optic glioma is. In addition, more than half of these patients, the tumors have a duplication of a fusion gene between KIAA 1549 and BRAF on chromosome 7. So you also have some of them with a mutation at chromosome site 600, V600E mutation. And these two changes together allow the patient's tumor to be treated with a selective targeting drug, such as dabrafenib, which is a BRAF inhibitor, or trametinib or selumetinib, which are MEK inhibitors, so affecting this first pathway. And here is our little girl before taking dabrafenib, as I showed you, this big mass involving both optic nerves, the chiasm, and going into at least the left optic tract, and I think a little bit into the right as well. After 1 year of dabrafenib, not only is the enhancement almost completely gone, but the tumor has shrunk significantly. This is a patient from the literature. This was a BRAF inhibitor, vemurafenib. And you can see 2 cases, both of which dramatically improved from A to D, and the far left to the far right, dramatically improved with a BRAF inhibitor. These were V600E positive tumors treated with that. Here's another patient of ours, pre-treatment. You see this huge mass in the chiasm after 3 months of a combination of the BRAF inhibitor, dabrafenib, and the MEK inhibitor, trametinib. You see this dramatic improvement. Another from the literature, these are V600E negative tumors, massive tumor involving the orbital optic nerve extending through an enlarged canal and into the chiasm, this large mass. And after 18 months of treatment with trametinib, fair amount of tumor still there, but it's decreased in its size and decreased in its enhancement. So the change in practice is that treatment now for these optic pathway gliomas can be targeted based on molecular biology. And so at this point in time, these are not first-line treatments, but be aware that your patient with an optic pathway glioma who has severe visual loss, if that patient is not responding to standard sort of vincristine, vinblastine, actinomycin D, etc., it may be possible to biopsy the lesion, identify whether it has a V600E mutation or a fusion mutation, and treat the patient with targeted therapy. So to summarize, consider NMO or MOG in all patients with acute optic neuritis. I would recommend obtaining anti-aquaporin 4 and MOG antibodies in all patients with acute optic neuritis. I recommend treating all patients with acute optic neuritis with high-dose systemic steroids unless you have an etiology, and be prepared to begin plasma exchange if there's no improvement in between 5 and 10 days. For Cryon, if you've got a patient with chronic, recurrent, steroid-sensitive, steroid-dependent optic neuritis, check that patient for MOG antibodies. And even with the 1%, or say 99% sensitivity, so 1% false positives, even if you've done a MOG antibody study, check them again. And these patients need long-term immunosuppression with drugs such as these various monoclonal antibodies like rituximab. For primary pseudotumor, for patients with mild to moderate papilledema, at least discuss early on the option of bariatric surgery, and maybe even refer select patients for bariatric surgery instead of attempting to place the patient on a weight loss program, which isn't going to work. And also for patients who require more than medical intervention and who have evidence of venous sinus stenosis, as most do, I would consider referring for venous sinus stenting. Finally, for optic pathway gliomas, consider using, or at least discussing with your pediatric neuro-oncologist, the use of targeted therapy for patients with optic pathway gliomas who present with severe visual loss or whose visual loss progresses despite the standard non-targeting therapy. And that, I think I'll end because the time is up, and we can look at questions. So
Dr. Miller, thank you for that presentation. That was fantastic. There's a couple questions for you here. Do you recommend testing for NMO or MOG antibodies in patients presenting with non-arteritic ischemic optic neuropathy?
No, I think that I would only do it if I'm not sure whether it's an AION or acute optic neuritis. I mean, there's no question that you get somebody who's in his or her late 40s or early 50s and maybe with a little hypertension, and there's acute loss of vision. And we know that traditionally we'd love to say that, well, if it's painful, then it's optic neuritis. If it's painless, it's NAION. And that's true to a large degree. But it was shown years ago that some patients with NAION do have some degree of pain. It's almost never severe. And if you have a patient with pain on movement of the eye, it is not NAION. Having said that, there are clearly cases in which one isn't sure, and it's not that expensive to go ahead and test for NMO and MOG antibodies.
Got it. Thank you. Now, another question we had here was, are you getting routine blood work for patients who are on long-term, especially higher dose Diamox?
No, that's a great question. We used to be, neuro-ophthalmologists used to be protected from the side effects of Diamox with respect to aplastic anemia and hypokalemia by our glaucoma colleagues, because they were using Diamox on a regular basis, and at least our colleagues weren't getting anything special. They weren't checking electrolytes at the beginning or during time. Now, of course, there are so many drugs that are being used instead of Diamox for glaucoma that it's the neuro-ophthalmologists who are using it. I do think that, having said that, I think that it is wise to get an electrolyte panel when you first, within a week or a few days after starting Diamox, and telling the patients about that. We do not routinely get them, consent them with information about aplastic anemia because it is so rare. And once the patient is on it, we have not been routinely getting electrolytes. It's certainly not going to hurt, but we have not found there to be a problem, particularly with the potassium issue in most of the patients. But a good question.
Got it. Thank you. A question for me, actually. So you mentioned bariatric surgery. Are you finding much uptake in your patient population with respect to going that route? Is there resistance?
To be honest, Amanda, we haven't started that yet because bariatric surgery in general was not on our radar, except for the massively obese patients, which quite frankly, as bad as the United States is in terms of obesity, most of the patients are not morbidly obese. So we haven't really, it hasn't been part of our armamentarium up to this point. But as I said earlier, we're going to be dealing with that more and more. I will say that the group in Birmingham, they tell me that they have not had that much resistance to bariatric surgery as they expected. For many patients, these are young women, they're often single mothers, they have jobs, and so the potential for not having to go to a weight loss clinic, several times a week, instead getting surgery that presumably will take them out of circulation for a short time, but then they'll be back, is not unattractive to them.
Yeah. Well, neuro-ophthalmologist Imran Jivraj has a burning question about dyspnea and Diamox on high doses.
Maybe we haven't asked the right question, but we have not had patients who've had to stop it because they complained of shortness of breath. I don't know what, I see that Ed and Jonathan are on, as well as you, Edsel. I don't know if you guys have had that experience.
I have not, and at least back at Wills, they were going up to doses of 3 to 4 grams.
Yeah.
If I could just make a quick comment.
Sure.
Sorry. I agree. A great talk, Dr. Miller. And I agree with bariatric surgery is definitely an excellent option for IH patients. In Ontario, we have a couple of barriers to obtaining this. One is we have a very long wait list. So here we'll be lucky if the patient gets surgery in 2 years. So the other thing is there's a lot of contraindications to bariatric surgery, like smoking, psychiatric comorbidities. And at least here, patients have to do quite an extensive pre-op assessment. So it requires endoscopy, medical evaluation. So it's very tough for us to get it in a timely manner, and especially in Ontario where we're struggling with operating room time access.
I understand completely. It's funny you say that, because years ago when I had several Canadian fellows, the joke, as it were, used to be, I would say something about, you need to get an MRI. And our fellows would say, but what if we can't get an MRI in a reasonable amount of time? And so these are the realities. I agree completely, by the way, about the psychology. Our bariatric surgery group does the same thing in terms of you have to have a very careful psychological assessment and all sorts of things that have to go on before they will do the surgery. The difference, of course, is that we can usually get a patient in right away. But that's why I mentioned that if you're going to change practice, you need a buy-in. And maybe I should have said it that way. You need a buy-in from your bariatric surgery group that they will fast track your patients in.
Thank you. There's another question here from Dr. Epstein. What amount of vision improvement would allow you to hold off on plasma exchange?
Well, that's a great question. And I don't know. I would say something from, I can't give you a logMAR score. I think it's just what the patient and I would consider significant improvement. Now, it's not 3 lines on the Snellen chart. But if somebody, for instance, had counting fingers and now is 2,200, I'd be willing to back off that. It's really the patient who is getting worse or is not getting better at all, or the patient who maybe had hand motions and now they're counting fingers. I'm not sure I'd be comfortable with just sort of following that patient. So a lot of it depends on the severity of the initial visual loss, and then whether they're getting better from what you consider and the patient considers significant visual loss.
Well, thank you. Those were fantastic rounds. I'd like to, on behalf of the department, I'd like to thank you, Dr. Miller, for joining us this morning, and Dr. Ng for facilitating these rounds. I think that was an excellent overview, and many of us, myself included, are leaving with pearls today that will help us in our practice. So thank you very much. So I'll allow you to say some words and close it out.
Yeah, thanks, Amandeep. And thank you so much, Dr. Miller. What can you say after a talk like that? Dr. Miller is the neuro-ophthalmologist. Thank you so much for sharing your time with us. There are some resident rounds going on after this. If you want to get more pearls, I'll be attending. But thanks again, Neil.
Thank you so much for having me. It's been a pleasure.
All right. Have a good weekend, everyone.
Bye.